Hello, I'm Dr. Ken Ellenbogen, and I'm a professor of cardiology at the Virginia Commonwealth University School of Medicine in Richmond, Virginia. I'm here in Boston at the Heart Rhythm Society annual meeting, and it's really my pleasure to be here with Dr. Randall Lee. Dr. Lee is a professor of medicine and cardiology at the University of California at San Francisco. And at this meeting, Dr. Lee presented a very important and new late-breaking clinical trial entitled Percutaneous Left Atrial Appendage Exclusion using the Lariat device in patients with atrial fibrillation. Initial clinical experience and long-term results. And Randall, welcome, and tell us a little bit what the Lariat is.
Okay, thank you, Ken, for having me over here. What the Lariat is, as we both know, the most severe consequence of atrial fibrillation is a potential of an embolic stroke. And what we did is we adapted a surgical procedure that has been done for over 70 years, which is suture ligation of the left atrial appendage. And the left atrial appendage is the presumed primary nidus for embolic events. So what we did is we took that concept of just tying off the left atrial appendage, and we made it into a closed-chested procedure in which we could use catheters, which we insert in the femoral vein, and then a pericardial access. And we basically have two magnet wires, one from the inside, one from the outside, which attach to each other, and they stabilize the appendage. And after we are able to stabilize the appendage, we then take a snare that comes over the appendage, closes down, and the snare has a pre-tied suture, and we release the suture, remove the snare, remove everything. So after we're all done, the left atrial appendage is excluded except for the remnant suture. So there's no implants, and we really see this as a potential for treatment of patients that have contraindications to anticoagulation therapy.
Now that we know what the device is, why don't you tell us a little bit about where the study was done, what the results were, and a little bit about the type of patients that were enrolled.
Okay. Well, the study was performed at John Paul II Hospital in Krakow, Poland. And one of the reasons we went there is I have a relationship with the surgeons there, and the center itself does over 2,500 open chest procedures a year. That's analogous to the Cleveland Clinic or Mayo Clinic here. So we went over there to really do a safety and efficacy study in terms of making sure that we could safely close the left atrial appendage. And the types of patients we chose were patients with atrial fibrillation that had a CHAD score of at least 1 and that had contraindications to Coumadin or intolerances, or had very labile Coumadin or INR levels, which commonly the patients had an embolic event on it. So that was the patient group. And we took those patients and we performed our procedure. And how we followed up in terms of looking at the efficacy is that we used transesophageal echo 1 day, 30 days, 90 days, and 1 year after the procedure. And we found that even after 1 year, our success rate in terms of completely closing the left atrial appendage was over 98%.
That's phenomenal, and clearly the clinical implications are major for patients who have AFib. So walk me through where we are now in terms of what type of patients might benefit from that and how this could evolve over the next 5 to 10 years.
Okay. As clinicians, one of the guidelines clearly state that patients with atrial fibrillation, especially patients with a CHAD score of over 1, should be on anticoagulation therapy. However, there are some patients that either have contraindications, meaning that they've had GI bleeds, they've had hemorrhagic strokes. They just cannot take anticoagulation therapy. So those patients would be, an ideal candidate. Other patients would be patients that have been on therapeutic anticoagulation therapy, but still had an embolic event. And then the other group of patients were really patients, the elderly, because they're at higher risk for embolic events, but they're also at higher risk for hemorrhagic strokes. And if you have patients that have increased fall risk and actually have fallen and have had trauma, those, in my mind, should be considered. And I think, with the newer anticoagulation therapy, we're going to see the incidence of hemorrhagic strokes increase, because right now the amount of patients that are actually treated with Coumadin is probably underutilized, meaning that if we had 10 patients, probably only 6 are being treated. But now with the newer drugs, what makes it easier, probably it's going to increase to 9 out of 10. And then the incidence, just absolute number-wise, we'll see an increase in the hemorrhagic strokes. So you'll see that use increase. And then the real question is as we get more experience with this, we'll start to do outcome studies to really look and see, the true benefit in terms of reduction of embolic events. And this will be down the road. And then at that point, it may have even more expanded use, because we all know that, at least from the PROTECT AF study, which uses an implant, it does seem to be at least non-inferior to Coumadin therapy. So that is the first study that implicates the left atrial appendage as a true nidus of embolic events.
So for now, patients who bleed on anticoagulation or absolutely can't take anticoagulation. In the future, we'll have to wait and see based on outcome studies and clinical trials. Well, it seems like the patients who have AFib, particularly in terms of stroke prevention, are going to have some pretty impressive interventional techniques to decrease their risk of stroke. This is really a major advance in cardiology, and I know you've been very involved, so we thank you very much for coming here and telling us about it.
Oh, thank you very much.